Today, when we discussed this talk, the goal was to talk about prevention. And I just wanted to frame prevention and discuss it as we do, which is we talk about primary prevention, secondary, and tertiary. So in primary prevention, there's the actual goal of preventing the onset of the illness. And a classic medical example would be an immunization to prevent the infection. Secondary is the early diagnosis and treatment, and tertiary would be the prevention of really complications from the illness and managing the illness. And so that's sort of a complicated thought when you think about psychiatric illnesses. Psychiatric illnesses are certainly very multifactorial, have a lot of genetic basis. So today's talk is going to be focused mostly on secondary and tertiary prevention. And why this talk? Well, women do suffer from depression at twice the rates that men do. The sex differences begin at puberty, and as you can tell from the chart, it's during the time of reproductive life, of reproduction, that women seem to have the highest rates compared to men. So the lifetime prevalence for women is 10 to 20%, which when we think about the burden of illness in society, that is a very high prevalence rate. And for men, it is half that. So my goals today are to discuss three illnesses, conditions that are are unique to women: premenstrual dysphoric disorder, perinatal mood disorders, and perimenopausal mood disorders. This is from a card that I found, and I always put this in because it's sort of a Rorschach for people. Specifically, I think it speaks to how commonplace the discussion of, quote, PMS is. This was just a card in a Hallmark shop. And I use the card sometimes with medical students and ask them to do a differential diagnosis. I don't have the bottom part there. And the real reflection is the amount of energy in the card, the sort of sense of things being out of control. And finally also, as you can't see in this piece of it, but there's a cord going in there from a vacuum cleaner, which speaks to the potential danger of premenstrual dysphoric disorder. So what is premenstrual dysphoric disorder? The formal definition in the DSM-5 is that a person must suffer from symptoms during the luteal phase only of the menstrual cycle. The luteal phase is the second half of the menstrual cycle, basically any time after ovulation. So the point here is that people can suffer from premenstrual dysphoric disorder symptoms for 2 out of 4 weeks of a month. That's a lot of suffering. One of the foremost researchers calculated the number of days of women in his clinic, Uriel Halbrook, and estimated about 3 years of severe suffering. The pertinent piece is that PMDD is grouped in the mood disorders because of the mood symptoms, and that's what differentiates it from simply PMS, which is more physical symptoms. And in premenstrual dysphoric disorder, one must have one of the top 4, which are the really unique phenotype of the illness of severe irritability, which is what the card was demonstrating. The other piece is that it must markedly interfere with activities. So the point being that about 40 to 70% of women in studies complain of premenstrual symptoms, but at the end of the day, only 5% actually fulfill this criteria of premenstrual dysphoric disorder. So how do we confirm the diagnosis? We do it through daily rating forms, and this is an example of a daily rating form. So if a woman comes into the clinic and says that she thinks she has premenstrual dysphoric disorder, we will encourage them to use these forms and do their symptoms for 2 months. Now, interestingly, we now have apps on cell phones for premenstrual dysphoric disorder. Has anybody ever seen one of those apps? There's a number now that are being developed. And as you can see from the slide, one must only have the symptoms prior to the onset of menstruation and maybe a few days into menstruation. So what are the risk factors? Well, life stress is clearly a risk factor. It's very interesting in doing premenstrual dysphoric disorder studies. Now, many researchers are really encouraging women to only come for the study at a time when they are not going to be going on vacation. That's how much it can really affect your symptom expression. And then history of major depressive disorder and family history of major depressive disorder are clear risk factors, as well as, interestingly, as one ages. And I would say that's one of the things that women are often very surprised by when they come to the Women's Wellness Clinic. Many people think PMS, or premenstrual dysphoric disorder, is a condition that mostly affects women early in their reproductive life cycle. In fact, the more children you have and the more close you are to perimenopause, the more often the symptoms will escalate and become very, very burdensome. So what can we do about it? Are there secondary and tertiary preventions, as it were, that can be used? Well, the first thing we used with women when they come to us, if they're not in an emergency or crisis, is what Dr. Stefanik was talking about, exercise. I can't tell you how often I have seen a woman with premenstrual dysphoric disorder that has described truly managing her life by vigorous exercise, and that she'll come in to see us often when she's had a condition like hurt her knee or her leg and can't exercise, and then the symptoms come at full force. Also, relaxation training and yoga have a few studies that support that, and I can say from working with women, they really do feel, again, and getting back to the previous slide where we talked about stress being an important risk factor. And also diet, minimizing caffeine and alcohol. Chasteberry, has anybody ever heard of chasteberry? It's used in Europe a lot, and it's been used for centuries. They used to call it the monk's berry because in medicinal purposes in the medieval times, they thought it decreased sexual interest. There's some animal data that suggests it is a dopamine blocking agent, which then decreases your prolactin levels, so it's helpful for mastalgia and pain in the breasts for some women. So these are the other one that does have clear scientific evidence and randomized placebo-controlled trials is calcium in large studies. So we really recommend that women make sure they're getting 1,200 milligrams a day of calcium. So what if that does not work? What are some of the other methods of decreasing the symptoms of premenstrual dysphoric disorder? Well, in order to say something is preventative, we would need to, for primary prevention, do the intervention prior to the onset of the illness, and we really don't have any studies of that nature. We do have studies, though, of women that are going on birth control pills, and then the study looks at their symptoms. And we do know that the original data that began the intervention trials were women going on oral birth control pills, usually the mini pill, and also the ones that have drospirenone and low-dose estrogen in them. And people said, I don't have PMDD, my friend does. So that got people quite interested because historically, oral contraceptives had often made women with premenstrual dysphoric disorder worse. So then they started doing intervention studies with these two specific oral contraceptives which have a unique form of progesterone. And actually, it was clear that it was significantly reducing the symptoms of premenstrual dysphoric disorder, and actually they got FDA approval for that. So what other things are helpful for premenstrual dysphoric disorder? I'll get to that in a second, but antidepressants. This is, again, another way to look at this question of prevention. Have anybody here heard of the STAR-D study? It's really an important study in psychiatry and ultimately in primary care, since so many primary care physicians are now, treating folks. It was a sequence study of antidepressant treatment. So people started the study on an SSRI Celexa, and then they looked at, it was naturalistic, what percentage of people met criteria for remission after 12 weeks. And they found that about 30%. So that's why when you read in the paper, antidepressants are not better than placebo. They kind of say the placebo response generally is 30%. Antidepressant response in this first step of the STAR-D was only that. However, they then sequenced it and went next step, next step, next step. And it was either changing to another antidepressant or adding cognitive behavioral therapy or changing to cognitive behavioral therapy. And then they had another wave of people who then met criteria for remission. So after several steps of the steps in this study, there were 4 total steps. 70% of people did meet criteria for remission. The take-home being that many people do not respond the first time to an antidepressant with the first antidepressant. And so they went back and they reanalyzed the step data to look at women and see how women did in this very large study, and found that women who were on oral contraceptives actually had fewer premenstrual dysphoric disorder symptoms. So again, there's this accumulating evidence that for many women, this is sort of a secondary prevention to premenstrual dysphoric disorder. Other medicines that are now FDA approved include fluoxetine or Prozac, sertraline, Zoloft, and paroxetine. And it's very, very interesting because they're used often in a very different way. I spoke to you about the definition of premenstrual dysphoric disorder, that it's in the luteal phase only that the symptoms occur. Well, actually, one can take these medications only in the luteal phase. And so the bottom line is they work in a different mechanism than in major depression generally. And what's fascinating is women with premenstrual dysphoric disorder do not complain of withdrawal symptoms, which many people do when they have been taking an antidepressant for depression, and then they stop their antidepressant abruptly. So the onset of action is quite fast. So now I was going to move on into mood and anxiety disorders in women. One of the myths that has lingered for, from the time I was in medical school and just recently is beginning to become well known not to be true, is that pregnancy cures depression. It certainly is not the case, and the prevalence of major depression in pregnancy is the same as across other periods of time from that first graph that I showed you of the reproductive age of women. When we talk about postpartum disorders, we talk about the blues, depression, and psychosis. There's sort of the 3 broad categories, but there's a great deal of new research about the actual conditions within these categories that I do want, if I was to say a couple of main things from today's talk of, quote, preventative measures, this is it. Postpartum blues is transient. There's really no way that we can prevent it. It's self-limited. However, we do need to be aware that about 20% of women who have the blues then go on to have postpartum depression. So if we were to talk about, quote, prevention of psychiatric illness in women, one of the take-homes would be that if you have a friend or a family member with the blues and you have a very strong family history of depression, that is something to take more seriously than someone who does not have that family history or does not have the blues. And what do we do then? We recommend that people be followed more closely and be much more supported. We know that social support is incredibly important for intervention in depression. Postpartum depression is basically exactly the same in the DSM-5 as unipolar depression at other times of a person's life. There are some very interesting and important sort of symptoms and characteristics of the illness that are important to know about because many women do not willingly speak of them. And they can interfere with early intervention in treatment, so that sort of tertiary prevention stage. One of them is obsessions. Women will describe having a unwanted thought of, for instance, throwing their baby over the banister or other violent imagery. And the cardinal piece is that it's extremely distressing to them. And so that's a place where we really want to intervene early. And medications and psychotherapy are the treatments. So postpartum psychosis is much rarer, 0.1 to 0.2% of women. However, this is a condition that is more common in women with a history of bipolar disorder. So again, when we think about prevention, you know, we can't do primary prevention really on bipolar disorder, but we can intervene early in women who are pregnant and going to give birth, because we have very good evidence that intervening is able to decrease the risk of having a postpartum psychosis episode or a severe mood disorder episode. So what are the risk factors for perinatal mood disorders? Now I'm speaking of postpartum depression here. It's been really, again, interesting to be in the field for many years and see the evolution of the concept of risk factors. So when I was in medical school, we mostly just spoke about demographic risk factors. And as you can imagine, those are areas where we really can't intervene on a primary level and very little on a secondary level other than antenatal depression, which is depression or anxiety during pregnancy. However, as the research has progressed, we're finding new and newer ways to intervene by going granular with risk factors, and I'm going to tell you about that. One of the next areas that's really consistently shown is stressful interpersonal events or relationships. And this actually is very important because it's formed the foundation of where our therapies now are. Interpersonal psychotherapy is a specific therapy focused on this. Then specific populations at risk, we have clarified that women who are currently having a high-risk pregnancy, for instance, or a birth of a baby with complications. But a couple of the last three I wanted to highlight for you, which is very, very interesting, many people are not aware of. One of them is the infant characteristics. I'll never forget, you know, many, many years ago, a woman coming into me and just sitting out of my office and just crying and crying. And she said, you know, I don't have depression. I don't even think I'm depressed, but my baby has colic and I can't stand it any longer. And now we know that colic is a risk factor for postpartum depression. And it's probably the disruption of sleep and the constant stress that the mom is under. The other two characteristics that are important are perfectionistic personality style as well as attachment issues. So when we talk about attachment, we think about how do people feel in relationship to other people in sort of a general way. Do they feel secure that they can ask for things and receive support? Do they feel insecure? They feel like, oh boy, I better not ask that person that, and what should I do? Should I be independent in this situation or not? We call that insecure attachment. And then avoidant attachment is where a person has had a tough life and they don't even expect anyone to help them. So they don't ask for help at all. And this has been an area, again, of interest in postpartum depression because studies are beginning to show that folks who have insecure attachment have a hard time postpartum, because one of my favorite quotes is from the psychiatrist Winnicott, who said, "There is no such thing as a baby." I remember when I heard that, I thought, well, what is he trying to say? But he's saying, you know, there's always got to be a care provider with that little infant. And it speaks to that huge responsibility that's there and how you can't usually manage it alone, and you've got to ask for help. And so people who have a tough time with that, studies are showing, have a harder time postpartum. Just to highlight this, we looked at 75 women in our clinic and went back through the charts and found that marital problems were a precipitant to the depressive symptoms for over almost half of the people. And these preceded the development of the symptoms. One of our new faculty, Thalia Rabakis, is very interested in attachment, and she has done a very interesting study that is still recruiting if you have any friends or family that are pregnant, looking at attachment and if it's a predictor for postpartum depression. And what she found, ASQ is the Attachment Style Questionnaire, and EPDS is the Edinburgh Postnatal Depression Inventory. And what she found here is that, this is so light, I'm sorry, that folks with insecure attachment on the antenatal attachment questionnaire did have higher rates of depression postpartum. Note, though, that the risk factor that I learned about early in my career and is still talked about so much today is a previous history of mood disorder. What was interesting is it didn't really emerge until later on, and the good news is this was associated with significant improvement over time. So that family member or friend who seems to have a not the blues anymore, but after about 3 or 4 weeks, a real depression, but does begin to respond to help and support. Am I doing okay on time? Yeah. keep going. So I just wanted to say preventive techniques include interpersonal psychotherapy, cognitive behavioral therapy, psychoeducation, and infant-focused therapies. And the techniques differ between the different therapies, but all of them have been found to be effective for the treatment of early symptoms of mild to moderate depression. So we would consider them secondary and tertiary preventions. I wanted to spend a minute on the fact that even though day after day we see women come in and say, I went off my antidepressant, can I prevent my postpartum depression from happening a second time by going back on the antidepressant? What is the evidence for this, basis for this? Unfortunately, we don't have a lot. We do it pretty customarily. However, there's only one trial. Sleep is a really important intervention to prevent postpartum depression. And there is a study going on at Stanford right now looking at cognitive behavioral therapy for insomnia. And then finally, does anybody know what this is? Yeah, that's the placenta. So placentaphagia is the eating of the placenta postpartum. And many people ask me if this is something that would prevent postpartum depression. We, again, do not have any studies on this. However, some people swear that it's been helpful to them. We really do not have any studies at all. What's pertinent is we do have studies looking at the use of progesterone and estrogen, and they, in randomized placebo-controlled studies, have not been found to be helpful. So in general, we do not recommend hormones postpartum. So in terms of tertiary prevention, we do really, this is the group of people that we must be vigorous in our screening and our treatment interventions. And it's folks with over 4 episodes of major depression in their life. And if a person has had more than 4 episodes of major depression, we recommend that they maintain their antidepressants for sure postpartum. And then in women with a history of bipolar disorder, this again is a very important group in which we can help to prevent mood episodes. And there's over 50% risk of a postpartum mood episode in a woman not on any mood stabilizer or preventative treatment. And so we recommend preconception counseling to really talk to women about this really significantly increased risk postpartum. Also social rhythm therapy, which is a very important form of therapy where people clarify like what their patterns are in their day and keeping to them. So regular sleep, regular mealtime, regular people that they interact with, regular activities, very important for bipolar disorder. And then finally, a prophylactic mood stabilizer. There's now a couple of studies that have shown that reinstituting lithium immediately postpartum will decrease the risk from 50% of a relapse to less than 10% in some studies. So this is an example of the EPDS. One of the questions for today is, what is screening? This has been a fascinating topic in my field because some people call for universal screening with the Edinburgh Depression Score Index. And it is the most widely used screening tool in the world, 57 languages. However, there's quite a debate about whether it should be universal screening because this is simply a screening tool and one needs to really clarify through a clinical interview whether there is depression. I think that the debate will continue to rage for a while. There are 4 states that do have mandatory screening for postpartum depression. The question is, where would you do it? And this is what's really interesting because you can see that picking up postpartum depression is going to be in multiple places, from the pediatrician's office to the primary care to the psychiatrist and to the OB. And so the question is, who should screen? And then the real issue is that if they get a high score, what are they going to do with it? Because unfortunately, there are not as many psychiatrists as we would like to see, and that are willing and able to take on this condition. So then I want to finish up on menopause. As we know, menopause is not a discrete event. It's an evolving condition or life stage, not a medicalization idea, but a life stage. But one of the things we see in psychiatry is early in the perimenopausal trajectory, mood swings, mood complaints that are sort of subsyndromal. They don't meet full criteria for a major depressive episode or full criteria for an anxiety disorder, but they definitely interfere with the normal life that the person's been having. And so one of the things we have to differentiate is whether it's simply menopausal symptoms versus the symptoms of a mood disorder. And you can see there's a big overlap. With the mood disorder, we would really worry about suicidality and the depth and interference of the symptoms. The risk factors included early menopausal traditions, so women who are having an early menopause. But the two things I want you to leave with are hot flashes and insomnia. And these are places where we can definitely intervene. Because one of the ideas is the estrogen theory of the insomnia, that the estrogen withdrawal is associated with hot flashes that then wake people up at night. So there are no studies published on the prevention of perimenopausal mood symptoms, no large studies that way. But we do focus on modifiable risk factors. And some of the things we really want to focus on are people with a previous history of depression, because women with a previous history of depression have twice the risk of developing a depression in the perimenopause. So there's multiple opportunities for treatment, that some of them are quite safe, such as gabapentin, and then the SSRIs and the venlafaxine. And you can see that the response can happen quite soon, which is, again, very optimistic because it can help with the hot flashes and some mild anxiety. Estrogen as monotherapy is not recommended, so if you're told, oh, I've got major depression, moderate to severe, I'm going to take estrogen to treat it, that is not found in the literature. It could augment the response, but it is not a substitute for an antidepressant. And bipolar disorder is a time of, again, higher risk for a depressive episode. So people should be followed very closely, and mood stabilizers can be adjusted. So my conclusion is that we really need future research to focus on prevention of psychiatric illness. The good news is over the last 10 years, we have more research on intervening at secondary and tertiary stages of prevention, but we really don't have any primary prevention. And we need to look at cost-effectiveness trials as well, because that's one of the real concerns with postpartum depression, that we're going to give all these screening tools, yet we're not going to have the people power to really take care of people.